Welcome to our web-based training series on malignant neoplasms, tailored for ICD-10 coders with a focus on oncology ICD coding. This training is crafted by our CDC Foundation CW team led by Dr. Ahmed, aiming to enhance proficiency in assigning accurate diagnosis codes within various healthcare settings, including hospitals, patient facilities, and physicians' office. Our comprehensive training plan adheres to the coding and sequencing guidelines from the 2016 5th edition tabular list, instruction manual, and alphabetical index of ICD-10. The series comprises of 4 detailed PowerPoint presentation sessions, each designed to build on the previous one, ensuring a robust understanding of malignant neoplasm coding. My name is Dr. Yusuf Ahmed. I'm a mortality classification specialist, ICD consultant at the CDC Foundation. This presentation is based on guidelines and rules for neoplasm mortality coding in ICD-10 2016, Volume 2. Additional explanatory notes and examples have been included without altering the original instructions from Volume 2, 2016. Notes and instructions can also be found at the beginning of Chapter 2 in Volume 1 tabular list, specifically focusing on neoplasms C00 to D48 on page 167. Further notes can be referenced in Volume 3, specifically in the alphabetical index to diseases and nature of injury, indexed as neoplasm, starting from page 435. Additionally, after the presentation, exercises will be provided to assess the understanding and effectiveness of the presentation in relation to the relevant sections of the 2016 ICD-10 Volume 2. The slide features a flowchart illustrating the ICD coding process related to medical certification and causes of death. The flowchart consists of 3 main blocks with sequential steps. Causes of death in a medical certificate refers to the international form and guidelines for filling it on Annex 7, page 203, direct ICD-10 coding, index, and tabular list. It involves basic coding guidelines from Volume 2, page 28, section 3.3. Selection of the underlying cause of death includes steps SP1 to SP8, and concepts and rules for mortality coding in Volume 2, starting from page 31, section 4. This flowchart serves as a guide for medical professionals on recording causes of death, utilizing the ICD-10 system for coding and selecting the underlying cause of death based on specific steps and rules outlined in the reference materials. There are 4 sessions on neoplasm coding. The sessions are: Session 1. This was held in April 2024, introduced neoplasm coding, whose aim was to understand the fundamentals of malignant neoplasm coding. The session emphasized the understanding of the behavior, topography, and morphology of neoplasm. Session 2 is the current session today, which will delve into understanding primary and secondary malignant neoplasm coding. The objective is to review the guidelines for coding malignant neoplasms, including multiple cause codes and secondary coding for malignancies. Session 3 will examine and discuss situations where there is more than one primary malignant neoplasm, aiming to address complex scenarios involving multiple primary malignant neoplasms and ambiguous site indications. Session 4 is the final session on metastatic cancer coding. Its objective will be to cover coding for metastatic cancers and to understand the concepts of metastatic from and metastasis to. The slides use a simple layout with clear objectives and topics for each section, emphasizing a professional and informative approach to neoplasm coding training. You may recall that in session 1 of ICD coding for neoplasms, we covered the behavior, topography, and morphology of neoplasms. In session 2, we will discuss the classification of malignant neoplasms as either primary or secondary. We will examine the ICD code ranges for primary malignant neoplasms along with the code ranges for secondary and unspecified sites of malignant neoplasms. We'll also review the common sites of metastasis and emphasize that a malignant neoplasm reported as primary should be treated as such, even if other neoplasms of the certificate are described as secondary or metastasis. Additionally, we'll highlight indications of primary malignant neoplasms, such as when the site is on the list of common metastatic sites, or when a neoplasm, not typically coded as malignant, causes secondary spread. Finally, we will describe 3 exceptions to these rules, including cases where the stated durations are longer than expected for primary malignant neoplasms, morphologies must match, and specific coding instructions for neoplasm not typically considered malignant. This sets the stage for Web 3 session, where we will delve deeper into the coding complexities and further refine our understanding. In today's presentation, where we will cover 5 critical areas in the decision-making process for determining whether a malignant neoplasm is primary or secondary. We will start by examining common sites of metastasis, which is crucial for distinguishing between primary and secondary neoplasms. Next, we will explore scenarios where a malignant neoplasm is reported as primary and the criteria for such classification. We will also highlight other indications of primary malignant neoplasms, even when not explicitly stated. Additionally, we'll address malignant neoplasms reported as secondary, including the criteria and evidence for this classification. Finally, we will discuss other indications of secondary malignant neoplasms, providing a comprehensive framework for accurate classification. By the end of this presentation, we'll have a thorough understanding of how to classify malignant neoplasms effectively for optimal patient care. When coding a neoplasm within the C00 to C96 range, it is crucial to determine whether the neoplasm is primary or secondary. The term primary site is defined as the tumor's site of origin or where the tumor originated. If the neoplasm has spread to other parts of the body, it is classified as secondary or metastatic. In cases where a death certificate is ambiguous about the primary site, efforts should be made to clarify this with the certifier. If clarification is not possible, specific instructions from Volume 2, Section 435B should be followed. This slide outlines the ICD code ranges for primary malignant neoplasms with examples. Code C00 to C75 encompass malignant neoplasm that are stated or presumed to be primary. The neoplasm is located to a specific anatomical site. Code 76 are assigned to malignant neoplasms of ill-defined sites, which are cancers that cannot be definitively identified as originating from a particular organ or tissue. Code C80 is utilized for malignant neoplasms without a specified site, typically described as cancer or carcinoma when the primary site remains unknown. Lastly, codes C81 to C96 are designated for malignant neoplasms of lymphoid, hemopoietic, and related tissues, also presumed to be primary. For secondary neoplasms, the code range is C77 to C79, secondary. And for malignant neoplasms that are unspecified to be primary or secondary, the ICD provides the code C80.9, malignant neoplasm unspecified. The list of common sites of metastasis is a valuable tool for identifying primary neoplasm because each type of cancer tends to have a characteristic pattern of metastasis. For example, lung cancer often spreads to the brain, bones, and adrenal glands, while breast cancer frequently metastasizes to the lymph nodes, bones, and lungs. When choosing between codes for primary and secondary malignant neoplasm, refer to the list of common sites of metastasis. This slide shows the list in alphabetical order. This slide is the same as the previous one, but is arranged by common sites of metastasis across body systems. This slide provides guidelines on coding malignant neoplasms reported as primary. When a certifier describes a neoplasm using the terms like primary, primary in, or originating in, the appropriate ICD codes to use are from C00 to C76, C80.0, or C81 to C96. ICD-10 guidelines recommend using the alphabetical index to find the correct code. Additionally, guidelines emphasizes that if the morphology of the neoplasm has been specified, one should first consult Volume 3 of the coding manual, as some morphologies have specific ICD codes that differ from these listed in the neoplasm table based on the site and behavior of the tumor. This slide outlines the criteria for coding malignant neoplasms as primary, even if not described as such by the certifier. It specifies that a neoplasm should be coded as primary if other neoplasms on the certificate are noted as secondary or metastatic. using the example of a brain tumor being primary if a lung tumor is labeled as probably secondary. Additionally, it mentions that neoplasm within the ICD code range C81 to C96 should be coded as primary unless the certifier explicitly labels them as secondary. The guidelines also instruct to disregard ambiguous qualifiers like probably to ensure clarity and accuracy in medical coding, thus enhancing the consistency of medical records and supporting effective treatment planning. This slide provides ICD guideline and two examples for coding malignant neoplasms as primary when they are not located in common sites of metastasis. In example 5, kidney cancer is coded as primary, C64, and lung cancer as secondary, C78.0. Because the kidney cancer is not a common site of metastasis and is listed in the same part of the medical certificate as the primary neoplasm. Example 6 shows lung cancer coded as primary, C34.9, because there is no other primary malignant neoplasm listed in the same part of the certificate, and kidney cancer is also coded as primary, C64, since it's not a common site of metastasis. These examples illustrate the coding rules when multiple cancers are reported, emphasizing the primary coding for cancers not typically associated with metastatic sites. This slide illustrates ICD guidelines for coding malignant neoplasms as primary, even if the site is typically known for metastasis under specific conditions, with two examples shown in the slide. Morphology and risk factors. A neoplasm should be coded as primary if its morphology suggests it is the primary tumor of that site or it is associated with known risk factors for that type of cancer. For instance, chronic hepatitis can increase the risk of developing primary liver cancer. Unique cases of certificates if the neoplasm is the only one mentioned on the death certificate and it is not described as metastatic. It should be coded as primary, except for lymph node neoplasms, which are coded as secondary unless explicitly stated as primary. Lung cancer specifics. Lung cancer should be coded as secondary only if another primary malignant neoplasm is reported in the same part of the certificate. However, lung cancer described as bronchogenic or of the bronchus should always be coded as primary. These guidelines help accurate coding of neoplasms, reflecting their origin and behavior, which is crucial for medical management planning and accurate statistical reporting. This slide covers guidelines for coding neoplasms on death certificates, focusing on when to classify a neoplasm as primary malignant, even if the certifier does not explicitly state it. Here are the key talking points from this slide. Neoplasms not described as primary but causing secondary metastatic spread should be coded as primary malignant neoplasm, provided an appropriate code exists. This includes neoplasm like meningiomas that are not typically malignant but cause metastasis. In example 2, where a lung tumor causes brain metastasis, illustrates the principle. Despite the brain metastasis being reported, the lung tumor causing the metastatic spread should be coded as the primary malignant site, C34.9, under the guidelines. The lung tumor is considered the primary cause of death, labeled as primary lung cancer. In another scenario shown in example 7, where a brain tumor and a lung tumor are reported, with the lung tumor possibly being secondary, both should be considered malignant, because the mention of one tumor being secondary implies a primary malignant elsewhere, thus supporting the classification of both as malignant. The coding rules are supported by Volume 2 Guidelines, Section 435A. This slide outlines two key exceptions for coding primary malignant neoplasms in death certificates. If the death certificate includes the duration of secondary neoplasm must not be longer than the primary malignant neoplasm. Additionally, if morphologies are stated, both the secondary and primary malignant neoplasm should share the same morphology. And if a neoplasm not typically coded as malignant is implicated as causing another such neoplasm, both should be coded according to the alphabetical index without assuming malignancy or metastatic spread. This slide provides guidelines for coding malignant neoplasms reported as secondary in medical records, directing users to the neoplasm secondary section in the alphabetical index. Codes C77 to C79 are used for secondary malignant neoplasm depending on the anatomical site affected, such as lymph nodes, respiratory, and digestive organs or other sites. The coding list categorizes neoplasm into 5 types: primary malignant, secondary malignant, in situ, benign, or of uncertain behavior of unspecified nature, with specific examples provided for coding secondary metastasis in different quadrants of the breast. This slide addresses the coding of malignant neoplasm when stated morphology does not match the anatomical site of the neoplasm and is not specifically described as primary or secondary. When the morphology is indicated, such as osteosarcoma of lung, typically originates from a different site, bone, then the one reported, that is lung, codes are instructed to use a code for a malignant neoplasm of unspecified site that matches the morphology. In this case, C419 for osteosarcoma of an unspecified site. Additionally, coders should also code for a secondary malignant neoplasm of the lung, C780, to reflect the reported site. This slide provides guidance on coding malignant neoplasms specified by a certifier as secondary. Using an example where a lung tumor has metastasized to the brain, the lung tumor should be coded as the primary site of malignancy, C34.9, while the brain is considered a secondary site due to the metastatic spread. In the given example, kidney cancer is coded as the primary tumor, C64, because it is not typically a site of metastasis, while lung cancer is coded as secondary, C78.0. This coding decision is because lung is a common site of metastasis, and both cancers are reported together in the same section of the medical certificate, with kidney cancer being considered the primary source. Cancer of the cervical nodes is always coded as secondary, C77.0, assuming it is secondary to an unspecified primary malignant neoplasm. This coding practice is consistent with the general guideline that lymph node cancers are considered secondary unless proven otherwise, indicating metastasis from another primary site. In the provided examples, neoplasms with different morphologies are considered primary even if one of the sites is commonly associated with metastasis. For instance, transitional cell carcinoma of the bladder and osteosarcoma of the knee are both coded as primary malignancies, C67.9 and C40.2 respectively, because they have distinct morphological identities and neither is stated to be secondary. Conversely, carcinoma of the adrenal gland is coded as secondary, C79.7, because it is specified that the primary cancer is in the kidney, C64, indicating that the adrenal gland tumor is a metastasis from the kidney. When coding neoplasms, if the duration of unspecified neoplasm is longer than the malignant neoplasm reported as its cause, it should not be coded as secondary, regardless of the commonality of its site for metastasis. In the example provided, both osteosarcoma of the sacrum and clear cell cancer of the kidney are coded primary neoplasms, despite bone being a common site for metastasis, because they differ in morphology and neither is described specifically as secondary or metastatic. The coding rules emphasize that the order of entry should not influence whether neoplasm is considered primary or secondary. Instead, it should be based on explicit description of the neoplasm as secondary or its presence on a list of common metastatic sites. The next CWT in August 2024, session 3, is on more than one primary malignant neoplasm, sites not clearly indicated, primary site unknown, and overlapping sites. The objective will be to tackle complex coding scenarios involving multiple primary malignant neoplasms and ambiguous site indications. The presentation will be based on Volume 2 Instruction Manual, Section Page 11 Rules, and Guidelines for Neoplasm Mortality Coding in 435B, Malignant Neoplasms, ICD 10-2016, Volume 2, available at the website shown below. Thank you very much.